Okay, welcome back everyone. Today we're going to discuss about the wound healing complications. Right, so let's see over here. We have one question, as like the previous lectures. A 50-year-old, the Caucasian man presents to his dermatologist for a scar that is hindering mobility in right knee. Something that is hindering the mobility. That means this is the contracture, right? This is contracture. Okay, a few weeks ago he tripped and fell on a sharp rock, resulting a 6 centimeter cut. Okay, the size of the wound is how much? 6 centimeter over his knee. Since then his cut has healed in a raised pink, remember, raised pink scar has grown over a wound. On physical exam it is exactly 6 centimeter. Here the scar is equal to the size of the wound, okay, without growing beyond the original wound, and is pink and shiny. His right knee does not fully extend due to the scar. Yes, we already discussed. If it does not extend beyond the scar, due to the scar, this is what the contracture. To prevent further contracture, the physician discussed the possibility of surgical excision. Okay, so this is the treatment, right? So few points I want you to remember over here. What is this one? Raised pink. Raised pink. This is the sign of immature scar. Is that okay? Immature scar is pink and it is raised. Is that okay? And it is hard as well, and it is itchy as well. That means if these features are there, we have to understand this is our word, the immature scar. After that, another point I want you to remember here, the scar size and the wound size are equal. If the scar size and the wound size are equal, this is our hypertrophic scar. If the scar size is more than the wound size, then this is called what? The keloid. That means if the scar it grows beyond the wound margin, or if it the scar size becomes bigger than the wound size, then we say this is what? The keloid. But in this question the scar size is equal to the wound size, so that we have to say this is what? This is the hypertrophic scar. So hope you understand. This is a question in the exam, please remember. Now let's go to the wound healing complication. Do you know what are the complications of the wound healing? The wound healing, it may produces the multiple complications. Number one, it may produce the scar, right? This scar may be atrophic scar, it may be hypertrophic scar, it may be the keloid scar, right? Or it may produces the infections, right, at the site of the wound healing. It may produces the incisional hernia, right? It may produces the wound dehiscence. Wound dehiscence means it's a separate topic we will discuss later. That means the suture opens, especially it occurs in the abdomen. If the suture open, that is called what? The wound dehiscence. Is that okay? It may produces the Marzolin ulcer. Marzolin ulcer, right? So this everything we will discuss in details, right? So let's continue here with the scar. So what is a scar? A scar you know already. The scar means that we discussed already in the previous lesson, where we will have the increased collagen type 3 synthesis, and where we have the prolonged inflammatory phase of the wound healing, right? So that was we discussed already. And what is the immature scar? Immature scar means the scar in which the collagens, right, the collagens, they lies parallelly, and then this scar is raised, bigger in size, right? The scar is bigger in size, it is itchy, and it looks pink because of the hypervascularity. Is that okay? So these are the features, and this is also painful. This is also painful. This is called what? The immature scar. And of course, remember, scar is always acellular. Question in the exam. And what is the mature scar? In the mature scar, what happens? Mature scar, the vascularity decreases, right? Because of the vascularity decrease, the pink color will lost and it becomes the pale, and the scar becomes flat, not the raised one, right? So the scar becomes flat and the itchiness will decrease, right? So this is our what? The mature scar. And the next point you have to understand here, immature scar has the strength less, right? But the mature scar has strength about 70 to 80% at 12th week, okay? And this continues to mature for 2 years. Is that okay? Continue to mature for 2 years, strength keep increasing. And one more point you have to understand, what increases the wound strength? Wound strength is due to the collagen fibers, And another point they can ask you in the exam, one amount of the collagen, number one, arrangement of the collagen, the wavy arrangement of the collagen. Is that okay? So that amount increases the strength less than the arrangement, so that the arrangement of the collagen is more important for the the strength of the wound. This is the question in the exam, not the amount. Just look at here, we have some examples. This is the normal scar, keloid over here, hypertrophic scar over here, right? So we can see the keloid, it becomes bigger than the wound size, but the hypertrophic scar is within the wound margin, right? So this probably is a burn wound. What is this one? The burn wound. Is that okay? And look at here the types of scar. We already said atrophic scar, hypertrophic scar, keloid. This is where is atrophic? Yeah, atrophic scar is over here, depressed, right? Keloid is over here and hypertrophic scar is over here. Is that okay? So see, the atrophic scar. Atrophic scar means what? Atrophic scar means the scar which atrophies, right? It appears as a depression at the site of wound. You can see in this the picture in the facial region, right? You can see the depressions, multiple pitings over here, right? Can you see this one, right? So this atrophic scar, it looks like the pale, flat and stretched. How does it looks like? It looks like pale, flat and stretched, depressed inside, right? So what are the locations? The locations are most commonly the face and then back. Is that okay? Back of the body, back side of the body. And most commonly examples is because due to acne, and then after the smallpox, right? After the smallpox, right? Or the chickenpox. It occurs after these two diseases, right? Commonly. What's the treatment? The treatment usually does not need. Is that okay? The treatment is not needed usually, but sometimes it may need the the excision and resuturing if it is bigger, as like if you have the the cosmetic problems like in the ladies. Is that okay? And one more point we have to understand, these regions, these depressed regions, right? These depressed regions has the thin dermis and epidermis, so that they are easily traumatized. So this scar are less hindering than this, because if the trauma occurs there, then it produces the bigger wound. That wound may produces the bigger scars later, right? So that should be careful. This was the atrophic scar. You can see some examples. These are the atrophic scars. Hypertrophic scar you can see over here, keloid over here, and the contractures, right? Contracture is not clear. We have another picture. You will see the contracture later. Now let's go to the hypertrophic scar. So the hypertrophic scar is the excessive scar tissues, right? They are excessive scar, right? But they do not cross the wound margin. That means what? The scar size is equal to the wound size. Is that okay? And this is more common in children, and here male and female, they suffers equally in this, right? So you should understand this one. And the causes, right? So we'll discuss about the causes over here. And in the cause is that, we have prolonged inflammatory phase, right? And if the wound healing, because of the inflammatory phase, if the wound healing is more than 3 weeks, right? So why inflammatory phase is prolonged? Maybe because of you are taking the steroid, right? You are taking the steroid, or maybe any kind of the immunosuppression, so that it causes the wound healing delayed, right? Inflammatory phase prolonged, that produces what? The hypertrophic scar. So this is one cause. On another point is that you have to understand, sometimes this scar may produces at the line of the skin creases, if they present over the line of the skin creases in the face, this is called what? The line of facial expression. Line of facial expression. Is that clear? Right? And here what happens, we have the excessive, of course the scar is what? The excessive collagen formations over here. And which type of collagen in the scar, that we know already. This is which type of collagen? This is collagen type 3. Right? So what is the pathogenesis? In the pathogenesis, the same thing it happens over here, you know this already, right? So what happens? Increase collagen type 3 synthesis, right? But all of these collagens are arranged parallelly, not haphazardly. Is that okay? Parallel arrangement of the collagen type 3. So remember this one point. Another point is that, right? Yes, so it appears within 4 weeks. 4 weeks means 1 month, and does not grow beyond 6 months. Is that okay? That means after 6 months it regress. Please remember about the hypertrophic scar. Is that clear? And the another point is that, right, yes, it heals more than 3 weeks, that we said already, right? So and another point, they have increased myofibroblast, and this increased myofibroblast, they causes the excessive wound contraction, right? So excessive wound contraction is also the cause for what? The hypertrophic scar. Please remember, histologically, what do we see? In the histology, we will see the type 3 collagen arranged parallelly, okay? Arranged parallelly. And then we will see right, the matrix is less within the wound, and then we will see the myofibroblast, because these are the components so that they produces the hypertrophic scars. Hope you understand, right? What is the treatment? Sorry, the physical examination. The physical examination that you know already, it is the scar which is within the wound margin, right? And then there will be the pruritus positive, right? And it is non-tender as well, because it's a mature scar, right? It is non-tender and usually present in the flexor surfaces, right? Flexor surfaces, and it is non-vascular. Non-vascular means it is pale, not pink. Hope you understand, right? So what are the physical examination findings? It is within the wound margin. This is very, very, very important question in the exam, right? Another one, pruritus is positive, and it is non-tender. It is present usually in the flexor surfaces, and it is non-vascular and it is pale, right? Non-vascular means it is pale. This is the physical examination. Let's go to the treatment. In the treatment, let's understand, right? Often it is not necessary to treat, because after 6 months it will regress on itself, so that we may not need the treatment. Another treatment you can do, if it is the linear scar, right? If it is the linear scar, then you can treat with the pressures. These pressures you can apply by the stockings, right? Or maybe the socks, or maybe the gloves, or like this type of tapes, right? So you can produce the pressures like this. Understand? And after that, what you can go for is that if it is the ongoing scar, then you have to go for the intralesional steroid like triamcinolone injection we can do, right? And similarly, if you have more than 1 year of this scar, right? You have to go for the surgical excision. Surgical excision. Is that clear? So hope you understand about the treatment. So first treatment is just wait for 6 months. After 6 months it may regress, and if it is a linear scar, you apply the pressures. Like these pressures you can apply by the maybe the silicone, or maybe by the stockings, maybe socks, or maybe gloves, anything else. Or if the scar is ongoing, by even after the pressures therapy also, you can inject the triamcinolone injections, right? It's a steroid. What is this one? Steroid in the lesion you can inject. After that, if it is not healed even after 1 year by this all the remedies, then you can go for what? The excision, right? So you can just excision, and after excision, of course, you have to go for the wound closure. Wound closure, is that okay? And it usually does not reoccur. It usually does not reoccur, right? So this is the new modality they have treated with the radiation, right? So they have treated with what? The radiation. And what can be the complication? The complication, sometimes if it produces the contracture, right? Contracture over the flexor surfaces, it may limit the extension of the limbs, right? And reoccurrence is very rare here. Recurrence is very rare. Hope you understand over the hypertrophic scar. Now let's go to the keloid. Is that okay? I'm just looking my notes because I don't want to miss any points for the exam. Okay. So keloid. Why we draw this word as keloid? Keloid means claw-like. Claw means, the how does the bird's claw looks like? They looks like this, right? So that the keloid, it grows beyond the wound margin, so that the surface becomes irregular. That means the margin becomes irregular. That's why it looks like the claw. Is that okay? So that we call this as what? The keloid. And another point you have to remember is that about 16% of the African people, they suffer from keloid. About 16%, remember. So it is more common in pigmented skin. Pigmented skin means what? African, Asian, right? Hispanic, right? So please remember this one. And it is common in adult, not in the children. Like hypertrophic scar was common in children, so this keloid is common in adult. And here, the female has more, the frequency than in the males, right? So hope you understand about the keloid, the some features. What are the risk factors? Number one is the pigmentation of the skin. Another one, genetic predisposition. That means if the father mother they have this one, they may also develop this in the children, right? And then the family history is also important. Family history, but the hypertrophic scar has no family history. And similarly in the burn, right? The burn scar, similarly the wound healing for more than 3 weeks, right? So they develops the keloid. So these are the risk factors. And what are the common sites? The common sites are, you can see in the image: earlobe, presternum, back of the body, above the clavicle, right? So these are the most common sites. What are the common sites? Most common is presternal. That means within the chest region, right? So this region, this is most common. Another common site is what? Earlobe. Similarly, you have at the back of your body, right? And then you have the supraclavicular region. And you can remember there is one triangle you can make. This is our the left shoulder, right shoulder, and this is my xiphoid process. This triangle, right? So the chest triangle. So this triangle is most common between the right shoulder, the left shoulder, and then the xiphoid process. If you make this triangle, so this region is the most common site for the keloid. Hope you understand. And the another question they can ask you, what is the least common site? The least common site you can remember as GAPES, gaps, right? So gaps means you can say genitalia, right? Similarly, you can say across the joint. Similarly, P for palm, and E for the eyelid, and then the S for the sole, right? So palm, sole, eyelid, across the joint, and then genitalia. These are the least common site for keloid. Please remember, these are the questions in the exam. Hope you understand, right? So what is the etiology? The etiology is, we already, right? Most commonly it is unknown, idiopathic, right? Another point is that the deeply pigmented skin, deep pigmented skin, right? The skin pigmentations. Another one is the genetics. We discussed already genetics. Is that okay? Similarly, we have the the surgery, burn, and vaccination areas. Big surgery or burn region or the vaccination regions, they develop the keloids. And here what happens in the pathology, it is similar to what is this one? Hypertrophic scar, right? But here what happens, the you have to understand is that um, hypertrophic scar, but yeah, the collagens, right? The collagens were parallel over there, but here the collagens are wavy collagens are wavy in the keloid. In the hypertrophic scar, the collagens were parallel, right? So this is the point you have to remember. Another point is here, they have increased growth factors. In case of keloid, what happens? Growth factor is increased, and that causes the increased synthesis of type B collagen. Type B collagen in the hypertrophic scars. Is that okay? Hope you understand this one, right? And another point you have to remember is that it appears by the by the 3 months to 3 years. So what is the timing of the keloid appearance? Timing is what? 3 months to year. But the hypertrophic scar was what? Appearing at the 4th week to 6 months, right? After 6 months it begins to regress. So this is the etiology. Hope you understand. And what is the physical exam do we see? In the physical exam, it is easy. You will see the bigger, right, shiny, you can see, I think it is right, tender margin. It is tender margin will be tender, and it is irregular, right? Irregular margin. And size is bigger than the wound size, right? It is bigger than the wound size. You will see these the features of the keloid. And then you can see it is what is this one? Hyperpigmented. And another point is that you have to remember it is pink and purple. Hope you understand. So these are the findings. Pruritus is present here. Okay, pruritus is also present over here. Biopsy with histology, we do this if the clinical diagnosis is not possible. If clinically we cannot diagnose, right, then we have to go for the biopsy with histology. In the biopsy with histology, we will see disorganized. That means in the remember, in the hypertrophic scar, the collagens were parallel, but here collagens are disorganized and wavy, right? The collagens are wavy and disorganized, and you will see the type 1 and type 3 collagen, which type 3 is maximum over here, right? And you will see the hypervascularity also you will see, right? So hypervascularity, in the hypertrophic scar the vascularity was less, but here the vascularity is more. And of course it is acellular, right? Acellular, because all the scars are acellular. Hope you understand. And for the treatment, let's see over here. Yeah, you have to understand over here, it does not regress on itself, as like hypertrophic scar does not regress. That's why it needs the treatment is mandatory, right? So that remember, the treatment is mandatory. What is the first line treatment? In the first line treatment, what you can do is that silicone sheet, application of the silicone sheet, plus you can give the pressure therapy plus you can do the triamcinolone injection. That means steroid injections, is like in the hypertrophic scar, right? And also you can apply, this is one. Second option is that you can apply the topical retinoids. Is that okay? Be careful while applying the topical retinoids. You do not apply in the healthy region. Is that okay? Apply only in the the unhealthy regions. And then the laser therapy you can do. During the laser therapy, if this does not work, then you have to go for the excision first, right? After excision we have to close, and then we go for the laser therapy, right? So if any scar which is more than 12 months old, right? So it does not heal by 12 months, then we will go for what, the excision, and closure. After that we will go for this one. And if the size is more than 0.5 centimeter big, tall, height of the keloid is more than 0.5 centimeter, if it does not heal for more than 12 months by this treatment, then we go for what, the laser therapy, right? So in the laser therapy, first of all we do the excision, we close the wound, and then we apply the lasers. Is that okay? We apply the radiations. Is that okay? And we have the newer technique nowadays. In the newer technique, what do we do is that we do the intralesional cryotherapy. Cryotherapy means cooling. Is that okay? Cooling and killing the tissues, right? So we'll do the cryotherapy, and then plus what do we do is that 5% of the imiquimod we inject. Imiquimod we inject. This is our new technique. And then in the surgical excision we can go for, if there is the contracture developed because of the keloid, then we have to go for the surgical excision. And this is the last option for us. This is the last option. And remember, this excision or the surgery should not involve the healthy area, because the keloid reoccurs, so that the reoccurrence should be avoided. Is that okay? So we can see some of the examples over here, right? The keloid, we have the hypertrophic scar, and these are the scars, right? We can see like this. We have some of the DDs of these scars. I think these are not important for you, right? And then what is the prognosis of the keloid? Reoccurrence is frequent, will not regress over the time. Hypertrophic scar reoccurrence is rare and may regress over the time, right? And some of the differences we have given over here that we know already, right? Hypertrophic scar is not familial, not race related, but keloid is familial and race related, like in the black race common, right? And hypertrophic scar, we have the prolonged inflammatory phase of the wound healing, and it does not get worse after 6 months. Here also, the keloid also, we have the prolonged inflammatory phase, but it worse after the 6 months, or it goes to years and years, right? So in the hypertrophic scar, male and female are equally affected, but in the keloid, the female has more chances than male. And hypertrophic scar was common in children, but keloid was common in adult, we discussed, right? And then hypertrophic scar does not exceed the wound margin, but the keloid scar, it exceeds the wound margin, that we discussed. And hypertrophic scar was not vascular and not tender margin, but the keloid was hypervascular. That's why it looks pink, as like the immature scar, right? And then it is tender margin, right? So hypertrophic scar, it subsides with time, but the keloid does not subside with time. And hypertrophic scar commonly present on the flexor surfaces, and keloid is present over the sternum. Most common site is the sternum, shoulder, face, back of the body, right? These are the regions. And similarly, the hypertrophic scar appears within 4 weeks, but the keloid appears in 3 months to years of trauma. This is very important, right? So the questions, please remember. And hypertrophic scar is raised, some pruritus, right? And here in the keloid it is painful, and pruritus is also there, right? And if you see histologically hypertrophic scars, right, the collagens are parallel, but in case of this, the keloid, the collagens are wavy, right? So this one differences we did. And what is the chronic wound? Chronic wound means that heals, right? Heals in more than 12 weeks. That means does not heal within 12 weeks or does not heal within 3 months. It takes to heal more than 12 weeks or more than 3 months. That is called what? The chronic wound. And the treatment for the chronic wound is that you have to treat according to the nature of the wound, right? So you can just do the excision, debridement, right? Debridement, and then you can treat accordingly whatever needed, right? So this is about the chronic wound. And usually chronic wound, usually we treat it surgically. Surgically means the excision and debridement, we do this one. Another one is the contracture. You can see over here, contracture means the joint will be hyperflexed or hyperextended. Is that okay? So that the patient, the mobility of the joint is decreased. And where does it occur? It usually occurs where the scar crosses the flexor creases or flexor lines and produces the contracture. Treatment is always, the surgical treatment. We just have to cut excise, and then we have to give the place to release this, the tension over the skin. So these are the complications of the wound healing. Hope you understand. you know One more complication of the wound dehiscence, and then the surgical site infection. These two topics we haven't discussed in this slide, that we will discuss in the next video. uh, Thank you very much. Please try to make the note and try to understand about the complications of the wound healings. Thank you. See you again.